Myelosuppression and cancer treatment in general does carry other toxicities besides the physical. So emotional, mental, financial, social. But for a cancer patient, from diagnosis on, there's a lot that's out of their control. When you're faced with that diagnosis and you kind of have a lot of these things done to you, you want to really try to work to make that patient an active part of their care team.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Oncology Clinical Specialist at ONS. And today we're talking with ONS member Kimberly Miller, Transplant Case Manager at the Nebraska Medicine in Omaha, Nebraska, about nursing management of hematologic complications. Kimberly has authored the associated chapter in the latest edition of ONS's Cancer Basics book. This episode is part of a series about cancer symptom management basics. The others are linked in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Kim.
Thank you. It's great to be here.
Well, to start things off, let's begin with a brief explanation of what myelosuppression is and why it can occur in people with cancer.
Myelosuppression occurs when the bone marrow is not able to produce the blood-forming cells. So myelosuppression actually causes a decrease in the blood counts. You can have neutropenia, which is a low white blood cell or low neutrophil count, is usually like when neutrophils are less than 1,500. You can have anemia, which is low red blood cells. And anemia is assessed on like a grading system. So you could have mild anemia, which is a hemoglobin less than 10, all the way to like a severe grade 3 anemia, which is like less than 8, or a grade 4 is life-threatening. You can also have thrombocytopenia or low platelet count, and that's characterized by platelets less than 100,000. There are a lot of different things that can cause myelosuppression. Sometimes it can be associated just to the disease that you have itself. So if you have a disease that involves the blood-forming cells, such as leukemia, then your ability to produce normal blood cells is going to be diminished and you'll have low blood counts. Also, if you have bone marrow involvement of your solid tumors, that could affect your blood counts as well. You can also have myelosuppression caused by chemotherapy, so the treatment for the disease. There are some diseases that are more prone to myelosuppression, some chemotherapy treatments. So, for example, patients who do have hematologic malignancies, such as lymphoma, leukemia, myeloma, might be more prone to having myelosuppression with their treatment. Also, there are some chemotherapies like platinum-containing chemotherapies, gemcitabine or carboplatin. Those are common chemotherapies that could be used to treat lung cancers or gynecological cancers or GU cancers. Those chemotherapies can also cause myelosuppression. Also, another form of cancer treatment that can cause myelosuppression is radiation, especially if a patient has pelvic radiation or spine radiation. You can also get myelosuppression just caused by complications of your disease. So patients who maybe have an acute lymphoblastic leukemia might have an enlarged spleen, and that could cause a low platelet count. Other causes of myelosuppression in people with cancer can be caused by just their age and their overall general health, independent of the treatment or the cancer. Maybe they have a lower bone marrow reserve because they're older, or maybe their kidneys or their liver don't work as well, so they can't metabolize or excrete some of the chemotherapy as well, so it sticks around in their system a little bit longer. Sometimes if their kidneys aren't working well, then they have kind of a baseline anemia to begin with. Also, myelosuppression can be caused by vitamin deficiencies. So sometimes that's important to look into those when you're starting cancer treatment.
So it sounds like every patient has 100 different ways that they could potentially have reasons for myelosuppression. And so that's a great episode because this is something that I think every nurse needs to know and consider for their patient, regardless of what their diagnosis is, what treatments they're getting. It sounds like there is likely going to be a potential cause for them to experience myelosuppression at some point during their cancer journey. So something to learn for everyone in this episode. So thank you for that very comprehensive overview to start things off. Let's move into what are the symptoms of the various hematologic complications that oncology nurses should be on the lookout for as they're kind of caring for and assessing their patient.
Yeah, I think it's really important to kind of talk to your patient and kind of see how they're feeling. There are some patients that have a better capability of handling like a low hemoglobin, and some patients are very sensitive to it. You can look at the numbers on their lab value, but you also have to kind of really talk to your patient and see how they're feeling. With neutropenia, there's not necessarily many symptoms that can relate to neutropenia. Mostly if somebody has a symptom based, related to neutropenia, it's because it's possible that they have an infection. So if they have fever or if they have low blood pressure or things like that, they could definitely have an infection. So that's going to be something that we talk about a little bit later, but that's going to be important to check for. With low platelets or thrombocytopenia, they could have bleeding complications. So they might have bruises. They might have petechiae, which are kind of that little kind of purple spots that they can get when those capillaries start bleeding. They can have bleeding gums or a nosebleed that's difficult to control. They could have blood in their urine. You have them watch for GI bleeding. Sometimes they can even get visual disturbance if they've got bleeding behind the eye. Patients who have anemia or low hemoglobin have symptoms more related to their decreased ability to transport oxygen. So they could be really tired. Their arms and legs can feel really heavy. They can be dizzy. They could be short of breath. They could have poor concentration, decreased appetite, be kind of lethargic. So those are kind of some of the things that patients can experience with myelosuppression.
Thank you for that. I mean, those are all, I think, assessments that as oncology nurses, we are very accustomed to incorporating as part of our typical patient assessment, but it does help to kind of pause and think, what are we really assessing when we ask those questions, and tying it back to what the myelosuppression is underneath that. I think it's always important to go back to those basics occasionally just to keep yourself grounded in what you're asking and why. So let's move into the potential complications that a patient might experience during myelosuppression. Can you elaborate on those complications?
We talked a little bit earlier about neutropenia. The biggest complication of that is obviously infection. So you do not have the ability to, number one, present with the normal signs and symptoms of infection. So you're not going to have redness and swelling and drainage and things like that. You're going to have more fever, hypotension. You might have, dysuria. You might have shortness of breath or cough or things like that. So neutropenic fever is considered an oncologic emergency. A neutropenic fever is a fever characterized when you're neutropenic, if you have a fever of 100.4 times 1 hour or any fever of 101 or greater is considered an oncologic emergency. Something that's really important to educate these patients when you're talking about neutropenic fever is you have to have a plan. What I always tell my patients is a midnight fever when you're neutropenic is a midnight phone call. So they have to know who they're going to call and where they're going to go if they have a fever at any time of the day, because they do need immediate intervention. Also, when your platelets are low, you have an increased risk of bleeding events. That risk is especially increased with trauma. So as we all probably know, cancer patients like to fall. Falls are kind of a big problem in cancer. So we have to always really educate our patients and understand that if you fall and if you hit your head, and your platelets are low, you need to be evaluated. Don't wait just because we don't know if there's going to be a risk of bleeding with that. With anemia, cardiac strain is something that could happen if you are anemic, especially if you have somebody who does have a cardiac history. We generally like to keep their transfusion threshold a little bit higher for that. I would say that life-threatening anemia is generally uncommon with chemotherapy-induced myelosuppression unless you have an episode that causes acute blood loss, because we are monitoring labs and we are watching the patient and we are transfusing when they hit a certain parameter. So that's a little bit less common.
Thank you for that. I mean, as I listened to you talk through those, it did strike me as that a lot of what can create very serious complications could be easily perceived as like not that big of a deal by patients or their family members, not in the context of having just received, maybe chemotherapy or radiation or something. If you were just kind of walking down the street on an average day, if you tripped and fell, you'd probably say, ow, or I have a bruise and move on with your life. Or a low grade fever, I'll just take a few Tylenol and take a nap. But like you said, it's important that we emphasize how it's different for somebody who is at risk for having myelosuppression or someone who we know already has pre-existing myelosuppression, and being able to clearly communicate why it's so serious, even though it may seem like not that big a deal, or even if they don't, immediately feel terrible. Like you said before, some of these don't have like obvious symptoms, or at least not in the beginning stages. And so it might be hard for the patient and their family to connect the severity with what they're experiencing, just because they might not immediately feel terrible. But again, that's all part of the education of just helping them to understand what's going on in their body, why this is different. And as you mentioned, very important to have that sort of action plan and steps that need to be taken when some of these symptoms do present, because there is no time to wait in certain circumstances. So I love the way you described that. So for these complications that you've just mentioned, how are they typically managed?
Generally, transfusion is going to be helpful in the case of low platelets or low hemoglobin. We generally have some standard transfusion parameters for people when they are anemic or thrombocytopenic. So that is simply replacement of those products. For neutropenic fever, they need to be evaluated soon, and then we evaluate for any possible source of infection. So patients can expect to have blood cultures, possibly a UA, a chest x-ray, a neutropenic fever. Typically, the patient will get kind of broad spectrum IV antibiotics, and most of the time they will be hospitalized.
So as you mentioned, transfusion is common to use in certain circumstances when this myelosuppression reaches a certain level. So there are some of those common parameters and guidance that we use. Can you talk us through maybe what is typical in terms of transfusion replacement?
Typically, platelets can be transfused if they're less than 10,000. A normal platelet count is somewhere around 150 to 400,000, but the risk of spontaneous bleeding events increases when they're less than 10,000. Now, if you have a pediatric patient, obviously those parameters are going to be higher, maybe less than 20,000, because kids like to rough and tumble and fall and get into all kinds of things. Also, if you have somebody who has a risk of bleeding, so say they have a history of a head bleed or history of a retinal hemorrhage or history of a GI bleed, then those patients, you're probably going to want to keep their parameters a little bit higher as well. But in general, for platelets, less than 10,000. For hemoglobin, some centers are a little bit different. Some say less than 8, some say less than 7. At our center, we say, in general, we transfuse red blood cells at less than 7, hemoglobin less than 7. But if they have a cardiac history, then we might transfuse them when they're less than 8. So that is going to be a little more dependent too on some patients get really symptomatic if they're less than 8. And so we might keep their transfusion parameters a little bit higher, but we do like to be conservative with red blood cell transfusions as well, just because there are complications to transfusion. With packed red blood cells, they could get a volume overload. The more transfusions you get, the higher your iron levels get. And then you can run into complications with iron overload. With platelets, you can get like an alloimmunization. So that's like an immune response from exposure to somebody else's cells. And that means that you could get an autoimmune response that destroys platelets. So you could become platelet refractory. You can also get transfusion reactions. You could, low possibility, but you could get infection from transfusions. And then you can also have actually some more serious life-threatening reactions from transfusions. So one of them is transfusion-associated circulatory overload, or TACO. And that kind of correlates with how much or how fast you're giving those transfusions. That patient can have respiratory distress or pulmonary edema. It can have cardiac complications. You could also get transfusion-related acute lung injury. That is like respiratory distress syndrome that can happen within several hours after giving a transfusion. So that's why we do like to be conservative with blood transfusions. We typically give 1 unit of packed red blood cells instead of 2, and just kind of be aware of what our transfusion parameters are, and definitely not over transfusing patients. Sometimes I always try to tell my patients more is not always better. So if they are tolerating, their hemoglobin sitting at 7.5, then I would rather wait until it drops down below 7 to give them a unit of blood if they're okay tolerating it, just because it does reduce the risk of complications short-term and long-term.
Sure, absolutely. I mean, you mentioned it that not only does each organization potentially have its own kind of parameters, but even over the course of my 15, 16 years of practice, what is kind of accepted or normal in terms of those transfusion parameters has also changed. I mean, we used to give it if someone was below 9, oh no, they're below 9. Quick, we got to transfuse. And now, as you mentioned, because of all those complications that we are increasingly aware of, thank you for talking through that, because I do think for oncology nurses that are likely very comfortable and familiar with the need to transfuse blood products, and it kind of becomes commonplace, but it's important to not forget that there are those complications that can become quite serious if you're not keeping aware of those and not taking it for granted that it's just another infusion that you're providing, but truly a transfusion of like living products. So that was a great overview of some of those not common, but certainly serious situations that can occur over time.
Yeah, some patients just get really nervous. If their blood counts get to a certain point, they get a little nervous. So I find that we just try to explain to them, we're watching your labs very frequently. We see you, several times a week. These are the complications that can happen, and just kind of talk them through the rationale for not giving a lot of maybe not necessary transfusions. So,
well, and sometimes that's the flip side of that, the nervousness of patients really being hesitant to want to get blood products. And sometimes it's having to not talk them into it, but present sort of the case for why it's safe and why it's certainly necessary at certain points, and trying to balance both of those considerations for patients depending on kind of how they enter into the need for a transfusion and kind of what their thoughts are about it. So we've talked a little bit about how to treat it. Are there parts or mechanisms of the myelosuppression that can be prevented?
Sometimes if you have a patient that gets their first cycle of chemo and they do have a lot of myelosuppression, then the physician might consider adjusting the intensity or the duration of the subsequent cycles in order to try to prevent myelosuppression. You can also look at other causes. So we talked about kind of some things you can't control, like age or other comorbidities, but there are some things we can look at. So we can check their vitamin B12 and their iron and their folate. And if they need supplementation for that, maybe that is enough to kind of help counteract some of the effects of myelosuppression on their hemoglobin. I think also just monitoring their labs. So, depending on the level of myelosuppression you expect, patients can maybe come weekly, twice a week, or 3 times a week for lab draws and can get transfusion or supportive care if they need to. Keeping in mind that, the nadir for chemo happens somewhere 7 to 14 days after therapy. And some patients can have myelosuppression for 3 to 4 weeks or maybe even longer, depending on what kind of chemotherapy regimen they get. So just kind of making that plan for the follow-up and the monitoring can hopefully prevent some of those complications.
Are there situations or certain types of patients that might benefit from the use of antibiotics or antivirals to help prevent or mitigate infection as part of their myelosuppression?
Yeah, in general, the guidelines are if you expect a patient to have severe prolonged neutropenia. So severe neutropenia is an absolute neutrophil count of less than 500. So if you expect that to last greater than 7 days, then you would want to consider giving them an antibiotic to kind of help prevent neutropenic fever. Generally, the antibiotic is a fluoroquinolone, such as like levofloxacin, because it provides gram-negative coverage. But, fluoroquinolones can also cause tendon rupture, and they can also cause a prolonged QT. So you have to kind of think about that with the patients. If you have a patient that is considered kind of a high-risk patient, so somebody where that the therapy is going to result in severe neutropenia, or if the patient has a lot of comorbid conditions like hepatic insufficiency or renal insufficiency that would contribute to myelosuppression, or if the patient is going to expect it to get like severe mucositis, so you have a break in that mucosal barrier, which leads them at higher risk to infection, or patients with like leukemias. So that's obviously the cancer is affecting your blood forming cells, so you're going to be myelosuppressed. So those patients would definitely benefit from that. As far as like antifungals, those are recommended for patients that have leukemia or MDS. Also, if you have patients who have demonstrated an increased risk for fungal infection, such as patients that are getting alemtuzumab, patients who are getting the CAR T-cell therapy are at risk, a higher risk for a fungal infection, as well as patients undergoing stem cell transplant.
As we talked about before, I think we're all maybe accustomed to seeing order sets that have some of these sort of prophylactic medications incorporated into the order set for the treatment regimen. And this is just a nice reminder of why that is, and help connecting it to why we do that for some and not others. And it's just that known high risk, maybe it's associated with the disease or the treatment regimen. But if there's that known high risk for patients to have the decreased white blood cell count or neutrophils, just wanting to prevent those sort of opportunistic type infections that might occur. That kind of explains why we might see those orders pop up occasionally for patients.
Yeah. And then I haven't mentioned yet the use of growth factor for white blood cells. So the colony stimulating growth factors are very helpful. That could even possibly help prevent neutropenia, prolonged neutropenia in patients undergoing chemotherapy. So that's kind of another thing that you can use. For the leukemias, they don't generally use a lot of growth factor, but other diseases, definitely it's more common.
Absolutely. And, my experience has been for those regimens or patients that are at, evaluated at high risk from the beginning, those will be used from the outset. Or as you explained, if a patient has 1 or 2 cycles and their counts kind of tank, then they might add that growth factor in for future cycles to try to, prevent a deep dive or those counts again. Along those same lines, when would like erythropoietin or similar drugs be used to increase the red blood cells?
Erythropoietin does have some side effects. So there is an increased risk of thromboembolism with erythropoietin. They did have some studies that showed maybe there was a shortened survival and tumor progression in patients with breast and cervical cancer. So they've been really conservative with erythropoietin. ASCO, or the American Society of Clinical Oncologists, did publish some guidelines in 2019 that said in certain clinical circumstances, including patients whose treatment is not curative in intent, and for those whose hemoglobin has declined to less than 10, then erythropoietin should be considered, that you should discontinue it as soon as the hemoglobin does reach a threshold of 10. But it is useful to help reduce the number of transfusions patients need. And erythropoietin is also helpful for patients with MDS, not necessarily receiving chemotherapy, but if they have MDS and are anemic, erythropoietin is used for those patients to help keep their hemoglobin above 10.
And certainly those nurses listening that work in infusion centers, they might have more common experience of perhaps administering this for patients that just have renal impairment and they have anemia associated with that. Man, back in the day, we gave this stuff to everybody.
Yep.
And then, and like you said, then it tapered off because there was some evidence that maybe it's not needed for everyone. Maybe there's other means that we can use to help, again, preserve that hemoglobin count. Certain situations it's still appropriate to use, but definitely not as routine as it once was when it first came out. And so last in line here, growth factors for platelets. Talk to me a little bit about what's available and how it's used.
Yeah, so growth factor for platelets is not necessarily used for myelosuppression due to chemotherapy. It is FDA approved for the use in severe aplastic anemia. It's FDA approved for patients, adult and pediatric, greater than a year old, with persistent or chronic immune thrombocytopenia, and also for hepatitis C associated thrombocytopenia. But they aren't generally used for myelosuppression caused by chemo. They do have some studies that patients with MDS, if they used the growth factors for platelets, they did have an increased risk of progression to AML. So we don't use it for MDS patients. And there also is an increased risk of thromboembolic events with those.
Good to know. And I think that's important, to translate that for patients, for them to understand that even though there are some drugs on the market that might technically be applied in a certain setting, it might not always translate to their specific scenario. And I think as nurses, we've become more and more comfortable having those conversations with patients just because there's so many commercials now on TV about this drug for cancer and this drug. And so we have to be able to kind of take that information and then, present it back to the patient to help them understand why or why not that drug doesn't apply maybe to their scenario or maybe not at the given time. So just important to keep those drugs in mind, even though they may not apply to patients who are receiving therapy for their cancer. So we talked a little bit about this, but just wanted to circle back to the symptoms of myelosuppression and how can they lead to other complications or emergencies that patients might experience?
Yeah, so we did talk about the oncologic emergency of neutropenic fever. Neutropenia could lead to sepsis. Also, myelosuppression can delay chemotherapy. So patients who are getting treatment for their cancer may experience delays in their next cycle. They may have dose reduction. They may have to discontinue that chemotherapy if they have severe myelosuppression, and that could affect their outcomes as far as their cancer treatment goes. Patients who are anemic, we talked about cancer patients like to fall. So if you are fatigued and your legs feel heavy and you're dizzy when you get up and you fall and your platelets are low as well, that leads to an increased risk of bleeding. And, really just the decrease in quality of life. So if you, have a lot of bruising and you have nosebleeds and you're falling and fatigued and, can't be around other people because your blood counts are low, then your quality of life is definitely affected.
That is something that's not talked about enough, of just relating the clinical complications to how that impacts the patient and the life that they're trying to live. So along those same lines, we know that these complications can affect patients in numerous ways, including socially and financially. How do you see the myelosuppression impacting patients beyond just the physical symptoms?
I just talked about the quality of life. I mean, that's really associated to fatigue, which can lead to depression and can lead to anxiety. Patients who, especially in the COVID era, who are myelosuppressed definitely can live in isolation. And so they don't really have that social support structure in place because they are afraid to be around other people for fear of contracting something when their counts are down. And so there's just a lot of fear, and that can really impact you. The other thing that you think about, though, is the financial toxicity. So if you are, undergoing chemotherapy and you're in 3 times a week getting blood transfusions and things, like, you can't work, you have a lot of doctor's appointments, you need somebody to be with you to help you out. So maybe your partner or your caregiver won't be able to work as well. There's gas, associated with trips back and forth and medical bills and all that kind of stuff. So, myelosuppression and cancer treatment in general does carry other toxicities besides the physical. So emotional, mental, financial, social.
Makes me remember the importance of sort of setting the expectation for patients and their families of what to expect. And there are certain diagnoses, there are certain very high intensity regimens where that transfusion is going to be part of the plan. You can't maybe decide right now what it's going to be, but you just know based on how intense the treatment is that that's definitely going to be part of their experience. And so, as much warning, as much heads up as you can give them, certainly I think helps them to be ready for that. I also think I remember many patients, what can I do to increase my hemoglobin? Well, nothing. We just have to wait. They want to do something active to bring their counts up, or they get very anxious if you have to dose reduce because they feel like, oh, I'm not getting the full dose. And so again, proactively having those conversations of like, this is part of our normal routine. Not everyone responds to the dose that is air quotes standard. And sometimes we have to ease that back if it's too much for your bone marrow to handle. And so proactively trying to have those conversations so that the patient doesn't feel like surprised by what happens and can kind of be ready to accommodate what the therapy throws at them.
Yeah. And I think that sometimes they take a lot of personal accountability for that. So sometimes they feel like they're doing something wrong if their counts are low and they're not recovering and things like that. So it is important to kind of have those conversations with them and just explain how chemotherapy works. And everybody's different. And some people might take longer to recover, and that's just who you are and how we'll handle it.
Well, Kim, as we come to the end of our episode today, I thank you so much for your time that you've shared with us and some of the great information that you've shared for our listeners. But I'd like to move into our quick fire questions as we wrap up today's episode. So to start things off, what are some common misconceptions about hematologic complications?
Something that's important to remember is not every single patient is going to have a hematologic complication with chemotherapy. Just because somebody starts chemo, it doesn't necessarily mean that they're going to be getting a lot of blood and losing their hair and doing all those things. There have been a lot of changes and a lot of advancements in the way that we treat cancer. So the therapies are getting a little more targeted and a lot more adapted to kind of how people respond to it and kind of help them manage that a little bit better. And I think the other thing is, I think when somebody thinks of somebody on chemotherapy, they think that they are getting a port place and coming in for IV therapy and, again, losing their hair and kind of looking like a cancer patient. But with a lot of the oral chemotherapies that can still cause myelosuppression, you don't necessarily look like a cancer patient. So just understanding that there's a lot of different kinds of therapies that can cause hematologic complications. So we do need to be aware of that when we're starting patients on anything.
Absolutely. And your mention of oral therapies is certainly warranted because, some of those aren't even cyclical. Some of those are just daily forever. They might not have the typical nadir. It might just be a slow, gradual decline of those counts. And so the way that you manage those and monitor them and intervene might be very different than what we would do typically with that cyclical IV regimen. So that's a great comment. Thank you for including that. What's something about this topic that's not often discussed, but you wish people knew more about?
I think a lot of this topic that we've discussed even today is kind of on the medical management of treating the complications, which is very important, obviously. But for a cancer patient, from diagnosis on, there's a lot that's out of their control. When you're faced with that diagnosis and you kind of have a lot of these things done to you, you want to really try to work to make that patient an active part of their care team. So I think it's important to talk with a patient, understanding that there's things that are out of their control, but there are things that are within their control. So you can teach them, this is how you manage the fatigue associated with anemia, or this is how you can prevent falls. These are the things you can do to prevent infection. These are the things, the nutrition things that you should focus on to help you feel your best. So anything that you can let the patient have control over, because their life has just changed dramatically and it's not the life they've envisioned for themselves any longer. And I think to give them some semblance of something that they can have control over is going to be really helpful for them emotionally, mentally, and physically.
Absolutely. And that's so important. Again, just as you said, including them as part of the care team, right? They have a role. And while their role might not directly treat or improve the myelosuppression, they do have the ability to do things to help themselves feel better, to keep themselves safe while their body is trying to recover, or the treatments that we are providing can help do their job. And so I love that tip to kind of include the patient as part of that sort of treatment paradigm, if you will. What are some additional training or education opportunities that oncology nurses need to better understand these types of complications?
I think the most important thing is really just knowing how to do a really great assessment for, how to assess for hematologic complications. So know what you look for in your physical assessment. Know what kind of questions you should ask a patient, or if somebody mentions a vague symptom they have, know what follow-up questions to ask them to kind of get a little more information. How to determine what types of education the patient still needs, again, to keep themselves safe when they're not under our wing in our cancer center. Kind of find out what resources the patient has to help them manage. So really looking at this as treatment of the whole person. So you have the hematologic complications, but all the other things that go with it. So doing your physical assessments as well as asking a lot of questions and kind of determining what their needs are from there.
I love that. And I think it's important, as you mentioned, patients will need information, they'll need resources to help them manage the symptoms that they're experiencing. And the nurse also has to be able to time, do I give that proactively? Do I give that before treatment starts? Do I wait until they start to have these complications and then I deliver this education? And sometimes that's both. And so just keeping tabs on how much your patient and their family, they're able to process. Do they have the deer in headlights look? Are they hearing what you're saying and trying to dispense that education maybe over time so that when it's important, they're able to hear it versus kind of front loading everything and just sending them on their way with their patient education binder and hoping for the best. So that's certainly a skill that I think we can always try to do better at. So speaking of those resources, are there additional resources that patients would benefit from having as part of their arsenal of information?
Your first instinct is always to go to the internet.
Right.
I mean, and that's what we do. That's what patients do. Everybody does. You want to look it up. So there are obviously websites that are better than others that have a little more reliable information. The CDC actually has handouts for patients about neutropenia and how to stay safe from infection. So, it's not an oncology based website, but it's definitely reliable. There are organizations such as Leukemia Lymphoma Society that have a lot of patient education about the leukemias and stuff, but there's also a lot of education just about chemotherapy and myelosuppression and how you manage those symptoms. So really anybody with any kind of cancer can go there and order that information. The American Society of Clinical Oncologists, or ASCO, has handouts called ASCO Answers. So those are kind of patient education handouts that are approved by ASCO to give out. So, they could look for that information. But also, like in the hospital, a lot of places have electronic medical records now, and a lot of places have built-in educational handouts that you can attach to the EMR after their visit and kind of give that reinforcement to patients as well.
Well, Kim, thank you again for all the wonderful information that you've shared with us today. It's certainly been fun talking through what is seemingly common for most oncology nurses, but just kind of getting back to basics and thinking through why it's an issue and how our patients are dealing with it. Do you have any final comments to share with our listeners today?
Again, to stress, it's just really important to see the person behind the diagnosis. So just try to be really patient-centered, which I know oncology nurses are wonderful at, kind of looking at the patient as a whole person. Kind of keep in mind that There are financial toxicities as well, and physical and emotional and mental. So it might just create, a bigger team of people that need to kind of step in and help the patient find the resources that they need to be successful. And then also don't forget about the caregiver. So the caregiver is a really important part of the team. Sometimes we get really focused on the patient, and we need to kind of step back and look at caregiver needs as well and see how we can help them best take care of their loved one.
That's a great recommendation. Thank you so much for your time today. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.